All right.
Are we live?
We should be live.
Ooh.
Let
All
me
right.
double check
Hello
on
and
YouTube.
welcome.
Yeah.
Sorry.
No, sorry. I guess we're live. Can somebody on the YouTube comments say if they can see us or not? And then we know we're live and we can start the presentation.
Until then, we'll just smile and wave.
Yeah. No, we should be live. Yeah.
Okay, great. So welcome everyone to this very special edition of our meetup chapter. We're hosting this session on the epidemiology of COVID-19. Wow, I really had to practice that word. And how we've been modeling this epidemic here in Belgium. This is us. You haven't seen our faces in a little while now. We're usually very present at the drinks after our meetups. But here's a little reminder of what we look like. Istvan, Jan, myself, Chris, Linda, and Tim. You may not see us, but we're still very approachable. So just reach out to us on Twitter, Facebook, Meetup, via email, LinkedIn, whatever way. If you have any ideas for future meetups, future speakers, you'd like us to invite, anything. So as I said before, this is a little bit of a special edition, and we said it already in the meetup description, but I'll say it again. We'd really like to keep the discussion here today quite technical. This is a data science meetup. It's not a political institution of any kind. We're all independent here. And so I understand that everyone has their opinion. I mean, it's our health that's on the line, so I get it. But we will be moderating the questions a little bit more than we usually do. So don't be mad at us if we don't tackle your questions specifically. It may just be because we don't have time, but also because it may be a little bit politically loaded. Please excuse us. And then I'll just hand the word to Tim, who can talk about his colleague a little bit more. Tim?
Okay, well, it is my pleasure and honor to introduce our next speaker. So Niel Hens is a professor of biostatistics at UHasselt University and also at the University of Antwerp. And his research interest is in the development and use of statistical methods, mathematical methods to describe infectious disease dynamics. He also received the prestigious ERC Consolidator grant in 2016 about this topic. And of course, Niel is now very well known as a member of the GS, so the expert group that is assigned to guide us out of this COVID-19 crisis. So Niel, the floor is yours, and thank you for being willing to give a talk for the data science meetup.
Okay, thank you, Tim. I'll start sharing my screen. And if all goes well, you should be able to see my slides now. So thank you for giving me the opportunity to talk about the COVID-19 epidemiology. And I would indeed like to stress that, as I've always done also in this crisis, I've taken a very scientific approach to things. I think you should separate all these things. So I'm very glad that we can focus on this. And I will tell you a little bit about how I got involved in this. So to set the scene and also to tell you a little bit more about working under time pressure and the challenge of doing this in a scientifically appropriate way. Before I do so, I have to thank a lot of colleagues. Colleagues within UHasselt University, within the University of Antwerp, and this is actually a collaboration that has been going on for quite some time now, especially within the SIMID consortium, which originated from a SIMID project that Philippe Beutels, who's a professor in health economics at the University of Antwerp, established. And then more and more, Philippe and I were working on this topic, and we continue to working on it. And in 2009, I got a chair in evidence-based vaccinology at the University of Antwerp, where I use indeed mathematical and statistical methods to better understand the epidemiology of infectious diseases. We have many national and international collaborators within the work that we do around COVID-19. I'm not going to go into detail here, but maybe a disclaimer is that we've always, the funding that we receive to work on this is all competitive funding, starting off with the ERC grant that Tim already mentioned. We were working on some of the topics that are, of course, very relevant within this pandemic. And especially one of the bold statements I've often made, and especially at the start, is give us one more year and we would be ready for this. Well, we would never be ready for this, I think. But at least we would have had the tools in place to step up, basically, and to do more advanced methodology and calculations. And now we were somehow faced with projects that were running already and that we had to shift gear and use other data and think about what the implications are, sometimes while running validations on the spot, sometimes while validating things a little bit later on, but nevertheless trying to get into this this peer review, which is essential for what we do. So I have 3 slides on the overview of the Belgian COVID-19 pandemic. The first case that was actually announced in the media as well was on the 4th of February. There was one repatriated Belgian coming back from Wuhan who tested positive for the novel coronavirus. That has no implications whatsoever, given that this person was isolated and did not infect others. But then at the end of the spring holidays, we saw a lot of importations from northern Italy. And by looking at the virus sequences and so on, actually Piet Maas at KU Leuven discovered that we already had presence of the virus before the spring holidays. But we didn't see it taking off, and especially the fire basically was really ignited with the returning travelers from northern Italy, from Austria, and also other places after that. On the 12th of March, we wrote a letter to the government to take this seriously, because there was a lot of hesitation, and we included some first predictions on possible peak size. There were a lot of numbers floating around, so we always expressed uncertainty related to that. It was very important, but it was almost inevitable, I think. And of course, looking back at it, you cannot judge it, but it was necessary to have to really mandate severe interventions, and finally a lockdown was initiated. So we call this a lockdown light in some sense. Of course, a lockdown is never light, but comparing it to lockdowns in different places, this was really a very important, or a relaxed version of that, let's say. There were many logistical issues, and I think it's fair to say that it was a logistical war rather than something else. On the 1st of April, I got in contact with the Prime Minister, who asked me to become a member of the Gs. And that was a very, well, I didn't have to think about that very long. And I said, yes, I of course want to contribute to providing expertise and knowledge to help us guide Belgium out of this lockdown in a very precise and good, orderly mannered fashion. There has been a lot of things written on this. I will not go in detail, but maybe a first thing that we try to do is we try to identify what we call exit phases. And the transition from one phase to another was a highly debated issue, is how much time do you leave in between? And what do you monitor in terms of allowing these transitions to occur? And on this, on the lower right end of the slide, you can see a diagram first proposed by Marius Gilbert, and we worked together on this to improve that. And it's actually a very simple way, and it was also the emphasis, because we needed to explain this to politicians, to broader the cabinets and so on. We wanted to have a simple way of explaining what defines these changes in this exit. And what you see on this slide is on the horizontal axis the new hospitalizations, on the vertical axis the hospitalizations daily ratios, and what you see here is that we started off the 26th of March at the top right, and then we moved along, and you see this very regular pattern appearing, especially here on the bottom right, and that's the weekly cyclus, let's say, the weekend effect, which people have talked about quite a bit. And then you see you're moving over these zones, and the idea behind these, what we call cliques, was really to think about growth rates, how fast does this epidemic grow or decline in this scenario, and new hospitalizations. Because you can have a steep growth with few hospitalizations, which you shouldn't worry about too much. But at the same time, you can also have the reverse. You have a lot of new hospitalizations, but the growth is actually not that big. But that could be very worrisome. And this was really looking at the level that we wanted to achieve in terms of keeping our hospitals running, basically, and the health system running. So I will not go into detail there, but what we've actually done there was what is called the hammer. The epidemic was really hammered, basically. It was really cut. And instead of exponential growth, we got really this curve, this first wave. And then what we are now in is the dance. And there was a lot of discussion on whether to call what we've seen in summertime a second wave or not. I don't like that discussion because that's not the idea. The idea is basically to keep the epidemic under control so that people, the population, is able to do more things again, and we can open up the society. But for doing so, you need to fight this pandemic with certain regulations or certain incentives and guide behavior a little bit. I don't like to talk about restrictions, but well, some things don't work without them, apparently. What is very important is how did we go about this? How did we go about this whole trajectory? And I couldn't have done that on my own, of course. I had a lot of colleagues helping me. And what was very striking initially was also the lack of data. The lack of data in terms of getting large surveys set up to know more about what is going on in the population. And one example is the large corona study, which was initiated in Antwerp with UHasselt and Leuven as well, which I will talk about very briefly in just a moment. We also started collecting social contact data because COVID-19 or SARS-CoV-2 is a respiratory virus. And when you have a respiratory virus, social contacts have proven to be very good proxies for the interactions between people. And of course, these interactions, they are actually the basis of how diseases are transmitted. People have to meet up first before the disease, respiratory pathogen, can actually be transmitted. And then you can talk, of course, about other transmission routes like fomites. But what we want to achieve with these social contact data is actually proxies for droplet and aerosol transmission. We've developed an app, a tool for other people to use social contact data, and so it's at your disposal. Anyone can use that. And that's also very important that we want to go as fast as possible towards an open science attitude. And as fast as possible, that doesn't mean that we're holding back on that, but of course, we need to check these data, double check them, because they can also be misused if not interpreted correctly. So data cleaning is a very important aspect of that. And this Socrates tool is actually developed because of my ERC project, where we're collecting data from different social contact surveys worldwide to make them available with even a link and so on to really go for the open science bit. And we could put that to practice right away in this crisis. Then, of course, we've also set up a new survey. Well, it's not of course. We've applied for a large European grant, an Horizon 2020 call, specifically devoted to COVID-19. And these comics data are collected, its social contact data are collected from panels. There's a company helping us with that. And these panels, they actually report each time they report on their social contact behavior. And this has been set up in the UK, in the Netherlands, and in Belgium. And now it's being transferred to date, 17 other European countries. We are aware that there are other countries that are also using these dictionaries and so on. So we're sharing everything we've got in terms of these comics data. And we hope also, and we will be contacting people actually to share it again within this Socrates tool, or a Socrates-like tool, I have to say, because maybe we will be splitting things because of the nature of the data. We also collected serological data. This is a study started by Harry Tate and Pierre van Damme at the University of Antwerp, where we collect residual samples in the population, and then we test them for the presence of IgG antibodies against SARS-CoV-2. Residual samples are not always the best samples. They're pretty much biased because, well, these are taken from laboratories, and people go for a reason to a laboratory, or the blood is going for a reason to a laboratory to be tested against certain pathogens. But in the past, these data have been shown to be very valuable, but there is an issue, a discussion that you need to have in terms of representativeness. But that's in every study you do. I think you need to be aware of these pitfalls, very important pitfalls also. And so also, if I go back to the large corona study, it's very important to consider that these data are biased by nature, let's say. There's always these people that are participating to these studies. Well, the hope is that, of course, these people believe in these studies as well. But I will come back to that. And then what is currently being set up is infectieradar.be. It's a system where we will invite people to subscribe to monitor their symptoms, basically, against well, not only COVID-19, but also for other pathogens. And it actually builds upon what has been done in the past, is the Grote Griepmeting, or the Great Influenza Survey, throughout Europe. So we're in connection with the Italian group at the ISI Foundation, who are actually developing this. A trial version has ran in the Netherlands, but there were some privacy issues, the data leaks and so on. So honestly, I'm very happy that we're not on the forefront there, but that we're the next ones to implement it. Hopefully that everything is solved. And in the past, we've already shown for influenza that this is a really useful tool. And also a tool, it's just a citizen science tool, again, with the usual issues there. But it will actually facilitate to run specific surveys asking people, what did you do when you had these symptoms? Did you go to work still or not? And so on. And these are very important quantities to know about, even if they are biased. To some extent, we can learn from them to inform the models that we develop. So what I will now do is I will give a little bit of an insight in these different data sources. I will keep that short. There are many more slides, and if anyone is happy, well, I'm happy to share slides again. Very much for the open way of doing things. And then later on, I will very briefly discuss 3 modeling exercises. Well, it's more than an exercise that we've done to try to understand the dynamics of SARS-CoV-2 and COVID-19, of course. So the large corona study, it's collaboration with many people, and the group is expanding. There's a lot of questions that have been posed. It's a weekly online survey focusing on the general public, self-reporting. To date, we have 18 survey rounds. The first survey round, we had more than 500,000 participants, so that's amazing. The last round that we now had, we still have 25,000 participants. That's not that much anymore, but that's of course not unexpected, but still 25,000 as a whole is a big number for a survey like this. In total, we have more than 2 million unique participants. So we're reaching a huge portion of the Belgian population, and we're reaching more people on the Flemish side than on the Walloon side. Although we've also engaged with ULB and other universities, this is not turning out to be the success or the balancing factor that we have hoped for. But nevertheless, we're very, very grateful that people are participating. And this survey, we have a few baseline questions, which are always the same, but we also adapt the survey according to public interest, let's say. And now what you will learn, we're preparing a press release on questions we've asked for the masks wearing in school, for instance. So just to point that we're approaching it from a very scientific point of view without taking any prerogative on what we're asking for. So some of the questions we pose: quarantine measures, monitor symptoms, mental health, public opinion with regards to the measures taken, contact tracing, and how people want to deal with that, and also an app, for instance. There's a lot of discussion took place about an app. We've also asked whether people would actually comply with installing an app and so on. And just to give you some illustrations, this is the symptom incidence based on the model predictions. We've done a spatial analysis on this. This is during the peak, the first wave. So you see a lot of colored places here, high incidence, especially in the northeast of Belgium, but also at other places. We've also looked at, for instance, questions like when did you have your last physical contacts? And what we learned there is that 65 plus already started before the lockdown was announced, already started on reducing their contacts, and that there is an age gradient in there, so that people 18 to 65, there you see actually that the last physical contact was more or less, the bulk of them was at the moment that the measures were instated, and then 0 to 17 were still a little bit later on. So that age gradient is important. That's also something that we've used to model this pandemic, because of course you need to know when people start changing their behavior. And it's not because there is a National Security Council where things are announced, basically, that people change their behavior. Some people do that before, some people do that after. It depends a lot on how this is mentioned in the media. So there is still a lot of research that would be really instrumental to link media and press coverage with intervention measures. The colleagues at the ISI Foundation in Italy are looking at this. Specifically on social media, on Twitter, and so on. Well, we're connecting with them for some of these things that are maybe still worthwhile to do, and maybe some of you are already doing this. So we would be very happy to discuss or link you up with the colleagues at the ISI Foundation. Some of the things that we've also done is try to link symptom onset with what did you do, basically, to a little bit of epidemiological research on where most contacts took place in terms of transmission risk. Of course, this is observational. It's a proxy. It's not the same, but nevertheless, it's what we are always thought it would be. Basically, there's a lot of at work. Nowadays that's still the same. At home, that's still the same. And then you see less evidence for links at public transport or in a food store, non-food store, and so on. And on the bottom line, on the x-axis, what you there see is people you're actually that are these participants. We see a lot of healthcare associated infections. That was at a certain stage. That was truly the epidemic stage. This was really transmission occurred in healthcare workers, also because of the lack of protection and so on. So a lot of signals that we can actually investigate. There's a lot more work being done, and definitely this data set is also underexploited at the moment. There's much more data than people to analyze it, and we're very happy again to collaborate with people. There, at a certain point, there was the announcement at the National Security Council that you could see 4 visitors. Then we've asked for, well, to what extent do you think most households will stick to the same 4 visitors? And what was very striking, this is just one graph of all these results, but what was very striking is a lot of people actually followed that rule of 4 visitors and not more. But a lot of people also thought the others weren't doing that. So the trust in the other households, let's say, was really down, let's say, compared to what was here. Although we had big numbers, remember, it's still biased. Having big numbers does not replace the lack of representativeness of this survey, so we still need to frame it correctly here. We can also look at the analysis of the incidence of infection, and the idea was to look at symptom incidence, connect that to, well, from the Corona study, and connect that to the data that Cienzano was collecting. I'll skip the details, but what we found was that a very significant effect. Symptoms incidence are a good proxy, at least at that time, for the COVID-19 incidence. We could look at improved maps of relative risks and so on. And well, the challenge will be, and especially now when we're approaching autumn, this will be not the best candidate anymore, because we will have common cold viruses popping up and so on, with symptoms that are very much intersecting with the symptoms of SARS-CoV-2 or COVID-19, since we're talking about the disease. So a lot to be learned there, and also to, well, how do you take other signals into account? And some of these other signals are, for instance, taking mobility data into account and so on, but I will not talk about that at this moment. So, of course, we can look at maps and so on, picture how this epidemic evolved over time, but I will not go into detail too much. I would like to move very shortly to Socrates, which is an online tool to talk about, well, to look at contact patterns. So what you can do with this tool, it's on socialcontactdata.org, and you can actually look at social contact patterns based on different studies, a lot of different studies in different countries. I think about, well, today I would say 17, but I haven't checked today still. But we're trying to add more and more. And what you can then do is look at the average number of contacts that people make in peacetime or before the pandemic took place. But there is also this distancing app where you can play with susceptibility, infectivity. You can play with, well, basically you can mimic what a lockdown would mean in terms of social contact rates and so on. You always have to be very careful. These are proxies, so you have to be very careful with using this and not overinterpret this. It's not a holy grail. Some people think it's the holy grail, but having been in this field for more than 10 years, I can tell you that social contact data should be correctly interpreted. What is then the follow-up of this? So we have social contact data in pre-pandemic times, but now we also have data from the COMEX study. This is a study that we've set up within this European project, this Horizon 2020 project, as I indicated before. So our setup is the same as compared to the UK and as compared to the Netherlands. So within the European project, we had 8 data collection waves covering a period of 16 weeks. We've needed to adapt that a little bit and also to be smart about this, given the scarcity in terms of funding. But what we collected is represented here. So this is the timing from March until July, and then you see which intervention measures took place, and each of these vertical shaded areas are different waves that we've collected data from. This is up until wave 6, but now we recently received the data up to wave 7, which we have postponed a little bit, so that's more oriented towards August, and we also expect wave 8 data to come in this week. So how does that go? Well, the wave, because it's quite a big data set as such, a lot of things to be checked, and then we can look at these data, and then what we do then, and have to explain this a little bit, is we have on the upper left panel, we have the Belgian data that we collected in 2010. The darker the color, the more mixing between age groups, and so you have the participant age group on the horizontal axis, the contact age group on the vertical axis, and the numbers in between are really the number of contacts that people make with a certain age category on average. So the average is very important. And then, so what you see on this first graph, in this panel A, is that people like to mix with people of the same age. And then you also see the parents and child mixing and so on. And this is a weighted matrix. That means that we weigh over the days of the week, as well as over females and males and over household size, because that is a very important component or confounder in this in these analyses. And then we have done the same thing with these comics waves. One downside of the comics study was that we could not, and that had to do with processing the ethical approvals. But since we're working with existing panels of 18 plus, we could not have information on children from 0 to 18 years. We're solving that. So we will have a prolongation of this comics survey for an additional 10 waves until the end of December, where we're also asking children about their contacts, but we'll do that via the parent. We know from past research that that's a good proxy. It's not brilliant, but it's fairly good. So to get better information. And what we see in these comics waves is a very important. So we see a reduction of the number of contacts. And what we see, for instance, in comics wave 6 is very important. There you see actually that 18 to 29-year-olds have made much more contacts at that specific wave. And if we then look back at the timing, then this was the timing that we've also seen some resurgence in the number of cases for this age group, and also that the age group where they were in contact with. So the 40 to 49. So that's very important. What we see in terms of social contact behavior is actually translated into incidence as well. I will not go into much detail anymore, but we've seen an increase in the number of contacts. So very importantly, but of course we're still lower as this 2010 data set. But it's very important to keep on monitoring this and to try to link these two things to see how to guide people in terms of what is possible in terms of number of contacts. We also looked at, so we had the number of contacts. This is number of contacts at home. Also there we see that if people can make more contacts elsewhere, they do it less at home. So that's a transition, let's say, over the different waves. And then we can also use these contact data to get an idea of the reproduction number. And actually, this is not it's actually not the best name on the y-axis. This is the relative R0. What does that mean? Oh, sorry, this is the R0. No, this is the R0. So during lockdown, we've been able to decrease R0 to a large extent. And if we would only use these contact data, then you actually see that today we would observe, or at wave 6, we would have observed an R0 of 1.5. Luckily, we didn't do so. And that could actually mean that our intervention measures, like wearing a mask or keeping the distance of 1.5 meters, meeting outside, and so on, that really works. Which one of those is responsible for this? That is something completely different. It's very difficult to disentangle those. And of course, we're using contacts, and the definition of a contact in these surveys is a two-way conversation of at least 3 words. That's of course, yeah, it's a bit of a mind-boggling definition. But if you think about it, it does make sense, and it originates from thinking about influenza in the past. And we can look at different levels of intimacy also for these contacts. So you can only look at contacts where physical contact, touching was involved, and then of course you have an R0 that is way lower. So by playing with that, basically, by investigating the relationships, you can actually formulate hypotheses in terms of what are the contacts that are most predictive for COVID-19 transmission. But you cannot claim causality, of course, and that's very important. That's a big limitation. We had some questions on mask use. Of course, this increased, and especially because masks were made mandatory at different places through time. Hand washing, you see a little bit of that going down. So it's still important then, if you want to encourage hand washing, that you can interpret these data and actually target the right population, let's say subpopulation, to do so. So I'm not going to go into conclusions too much. We're still working on this in much more detail now, but I think we have a lot of data to look at. For the serological data, I will skip that in the interest of time, because I do want to say something about some of these projects without going into detail. So maybe one of the most important papers that we worked on if in this whole period is the first one that we published, and it's the paper where we analyzed, or where we estimated generation interval based on symptom onset data. Unfortunately, we had no data of that kind in Belgium, and that also has to do with privacy issues and so on. But we did have data from colleagues in Singapore and in China. We've involved Dongxuan Chen, who could actually look at these Chinese data in much more detail, because of course he could translate this very much, could dig in these data and so on, to not make mistakes about these data. And for the Singapore data, we were pretty confident that these were complete, because in Singapore they have this tradition to work with these data, to collect these data in a very precise way. To cut a long story short, even when we took sensitivity analysis into account and so on, the biggest thing that we've been able to estimate, very importantly, is this table where we estimated the proportion of pre-symptomatic transmission. And here you see estimates of that of 48% to 77%. Now, a lot of people have misinterpreted that. They said, well, if 77% of all infections happen before symptom onset, then yeah, there's no way in controlling this pandemic. Well, the problem that people have done is they took this number and they didn't take the context into account, and that context is very important. This number is high because there were intervention measures in place. And if you leave out these intervention measures, then actually this proportion reduces substantially. And estimates are floating around. Again, there's a lot of uncertainty around them, but it's more 20% than 77%. So then some people have, so the first publication that looked at serial intervals was earlier than this work, but there the issue was they only had 7 intervals, and then they made big claims and so on, and this was published in the New England, and that was a problem, because a lot of the issue there with having just a few data points is, of course, that this is completely, this is not representative whatsoever, and that the uncertainty, the levels of uncertainty are huge. The opposite is also true. A lot of people have published on massive amounts of data and then claimed this to be the gold standard, to be true. But that's also not the correct way of doing it, because they've been throwing data sets on top of each other, basically, of analyzing that all together. And there's a lot of more, cleaning to be done, and different subset analyses that people have to look at. So that's a cautionary tale together with what we observed in this work. And then, well, there's a little bit on that, but to close, because I want to leave enough room for questions, we've estimated infection fatality rates and so on, but we've also done quite a lot of research or modeling work. And when we started doing this, we've developed 3 models: a metapopulation model, an individual-based model, and a stochastic compartmental model. And the simplest of all these 3 is the stochastic compartmental model. So, but what it allows is, with a few assumptions, to investigate the impact of several interventions. The data-driven metapopulation model was actually our preferred model at the start. Why? Because what we do is we have all the communes in Belgium are represented in this metapopulation model. People infect each other within these communes, and then people travel between these communes, and so they infect other patches in this model, and so on. And we thought that this was really a good model to start with, to work with. But that was not completely successful, and the reason is likely due to the large heterogeneity in the transmission of COVID-19. The super spreading and so on makes this very difficult. And then we have the agent-based model, and the agent-based model became our gold standard, especially in this exit strategy. And this, what a lot of people don't know about this model is we've developed this model in real time, informing what to do and what not to do. But at the same time, this model was also validated internationally with our collaborators and so on. So that's very important to take with us. That's an important feature. But at the same time, the principles that we've came across in this model are, of course, well, they're the logical things. And in hindsight, you can always say that. But at that moment, of course, you're investigating this. And so a lot of the things, and that's a highly debated issue, is the bubble concept and so on. But the bubble concept is something that we developed in the exit strategies. And what has in the meantime been proposed and so on is not something that comes from this modeling exercise. But what we wanted to show was, during this lockdown, for some people, this was really a terrible period socially. And what we wanted to offer basically was a way out in terms of bubbles meeting each other. And that's why we looked at this. It was a first step in this exit strategy. So don't overinterpret this as to what the measurements and decisions are today. But I'll show you one graph on the bubble concept. So there's a lot of data coming into this and so on. But this is a graph that is quite important. So what did we do? We have a baseline scenario on the left. And this was in the period May to July. And then we worked with household bubbles. We tried to reduce, working with household bubbles instead of random contacts and so on, reduces the incidence incredibly. Of course, because you're developing bubbles, you're actually closing the network of transmission. And then what we also done in this paper was also looked at contact tracing, because we can really simulate in an individual-based model of 11 million people. You can simulate what contact tracing really means. And then you have to compare the baseline with the contact tracing scenario here, and also that has a reduction. And of course, if you then would use household bubbles together with contact tracing, then this is pretty hopeful, right? You can actually lower things much more. We're currently revisiting that, having all the combinations together, but a lot of people already worked on this internationally, showing actually exactly the same things. So that's pretty reassuring. Okay, I think I've used more than I planned to do in terms of time, and I want to leave room for questions. So I want to stop here and thank you for your attention.
Cool. Thank you very much, Niel, for this presentation. Tim, maybe if you would like, can you go through the questions and offer some of them up to Niel?
Yes. Well, please feel free to add more questions on the chat. If I see something, Niel, and that you, of course, also mentioned clearly in your presentation, it's you do this survey study there is a problem with the bias, of course. The people responding to the survey might behave differently than people not doing. There are minority groups, very old people. Do they have access to laptops, etc.? Questions appearing a bit is, do you then take initiatives to engage also these other groups to find information from them? Or are there ways so that your model can cope a bit with this bias, although you cannot predict this? And how reliable are your results given this bias problem?
Yeah, so I think first of all, we need to acknowledge the bias. I think that's the most important thing to start with. But then indeed, not everyone has access to these or is accessing online surveys and so on. Something that we noticed as well when we started off doing this is also the time period in which you question people is very important. Some people go to work and then they come back later in the evening and they still want to fill in the survey, but they cannot do that anymore now. So we shifted some of the time periods and so on to partly to fight against that bias and to rectify that. We do balance things with what we do know from representative surveys. So there are some baseline questions which we can actually use to rectify some of that bias, but we're definitely not claiming that this solves the issue completely. So we still need to acknowledge that that bias is there. In terms of the minority groups, what we've done very much is from the start, we already indicated that we should have a very broad communication campaign. Also using this survey, that it should be broadcasted, basically, that people can participate from different minority groups. But what hasn't been done, we didn't have the resources, is that we go door to door and so on. So there is indeed definitely an issue that minorities are not represented within this survey. In the large corona study. But if I go back to the panel data, the panel survey, the contact survey, to some extent, and you don't need to be naive about this, people that participate in a panel are not always people from minorities, so you still have a bias there. But also there we try, the panel is representative in certain aspects, but not in all aspects. So we need to carefully interpret that. So we haven't solved the bias, and that's an issue here, but also because of the emergency setting, you don't always have the tools, the means to actually collect these data very quickly. So I think that infrastructure, honestly, is lacking in Belgium. We need to get these type of things. That's a lesson learned, that we need to set up either panels, including all these minorities and so on, or a system that we can question people very quickly.
Okay, thank you very much. I think that's a very clear answer. So in the meantime, also a lot of people are congratulating you for your impressive work and everything that you have done. Maybe another thing that has come up 2 or 3 times is the random testing. Let's not go into a political discussion, of course, but from a statistical point of view, from your mathematical models, if it would be possible, would it be meaningful now to do random testing on just without looking whether people have symptoms or not?
I think to answer that question, you need to distinguish between PCR tests and serological tests. So if you want to know what is the prevalence at this very moment in time, well, with both of these tests, that's still very difficult, but you can learn something from them, and you can learn also something more about that using the properties of that test. If we know quite a bit now on PCR testing. One of my colleagues, actually, who I visited last year, Justin Lessler, he actually looked at PCR testing and sensitivity, specificity, and so on. And we know fairly well how that works now. It's not brilliant, but we know that fairly well. We still detect a lot of dead virus and so on. So you need to take that into account. So having one snapshot of PCR testing, that likely doesn't do the trick. But having like 2 snapshots, well, that actually helps a lot. It's again, you can go on and on, of course, but if you would have 2 snapshots, you can learn a lot from the positivity rates in different age groups, how they change over time, and you can do the back calculation to some extent. It's not perfect again. There is the necessary uncertainty related to that, but actually the methods are there. The methods have been developed, and we actually even edited a book about that came out last year for some of these methods. In terms of serology, what we hoped for initially was that serological data would give us a clear idea of what happened in the past infection. And we realized that's not true. There is waning of humoral immunity. Well, I should say waning of the antibodies, which is not necessarily the same. And that's what we've also observed in these serological surveys that we've conducted in Antwerp, is that you see a decline again. So the valuable thing for serological surveys is, again, to do that, again, in 2 snapshots, not far up from each other, but we need to take that waning into account. So you need to follow up a group, a longitudinal study where you actually follow the waning, and then again you can do something with that. And that's actually we're setting out to do that now.
Okay, thank you very much. The third question is, maybe we see that you collaborate with a lot of people worldwide, which is of course nice to see. Do you also apply your models to data from different countries, and can we put this data together, or is it mainly comparing between countries, etc.?
We started doing this in collaboration with Vittoria Kolitsa and her group at INSERM. When we used the meta-population model, we worked on that together. So at that time, when the virus was not yet circulating here in Europe, actually one of the students of Vittoria came over because we had so let me rewind. So we developed a meta-population model to study influenza. Pietro Coletti was lead author on, or was working on that, to also develop that for France. And that model, that was a more advanced model than the one we had for Belgium. We started working on together with Vittoria. We adapted that to COVID-19. And then we said, okay, let's do that for Belgium, let's do that for France, next to each other. Also discussing some of the assumptions, but not everything, so that we could actually really challenge each other, basically. That didn't completely work because of the reasons I mentioned. The meta-population framework doesn't allow you to do that completely in a very accurate way, simply because the mobility bit doesn't work very, very well. It works to some extent, but not in a well-connected country like Belgium, for instance, and with a very spotty infection like SARS-CoV-2. So now, having said that, a lot of countries developed a model for their countries separately. Vittoria has done some other work where she looked at introductions in other places and so on. And currently, and that's why we have this European project as well, is to try to develop models that we now can translate into other settings in other countries. So the short answer is yes, we collaborated in terms of peer review of comparing models results with similar structured models, but maybe different in details. But we haven't worked with the very same model in different countries. And maybe one last thing to say about that is we've seen ECDC doing that. We've seen other people doing that. The London School of Hygiene and Tropical Medicine, one of the collaborators within this European project, they've done that. And one of the issues with these models, if you apply them to many different settings, is that you cannot reproduce the epidemics in the different countries very carefully anymore. So it's much more subtle in the different countries than what we believe it would be.
Okay, thank you again for this clear explanation. Maybe an interesting question for the data science community. So if you look at Kaggle websites or etc., we see a lot of popular machine learning methods like XGBoost, neural networks, etc. Are these techniques also used in your models? And if not, why not?
We're not using them in the models. We do use them for some of the data sets that we're analyzing, but we're not using them in the models themselves, because the models that we want to construct are really mechanistic models, where we can follow assumptions and look at what these assumptions mean in terms of reopening that part of society, another part of society, and so on. So we really want to do this as mechanistically as possible, of course, with the necessary sensitivity analyses. But yes, we are currently also looking at combining artificial intelligence with the models that we're developing. But this is a longer track type of research.
Okay. Maybe a more detailed question. Someone asked, is living density considered in the model, which is different from general population density?
It is considered in terms of the agent-based model has households in them, and all these households, they have sizes which are consistent with the Belgian population. So it's a synthetic population, but the household sizes are, well, it's almost a perfect match, let's say, with what we know from census data. So in that sense, yes, we do. Of course, what is very difficult to measure is how people, well, with the social contact data, we can do something, but how people mingle basically on a micro scale.
Okay, thank you. I don't know, Chris and Lean, did you see other questions coming up, or do you have questions? I think I've asked a couple of them.
So maybe one question on the models cannot be applied outside of Belgium. I'd like to reassure you they can, but you need to adapt them. If I take the household size distribution of Belgium, well, I'm not going to apply that in, let me say, Peru or something like that. So you need to change that. They're very different and so on. So the principles are very much the same. The building blocks are the same, but you need to adapt the building blocks towards the setting you're dealing with.
Okay.
I think there's one question we may have skipped from all the way at the beginning, where they ask, so there's two ways to gauge the effectiveness of a measure. They say you have, you compare two populations, your treatment and your control group, or you just apply the treatment to everyone, then release it and see if the release has any effect. What did we apply in our studies?
Yeah, it's a very good question. And some models have tried to do that. Recently, a colleague of mine, Mark Jitt at the London School of Hygiene Tropical Medicine, used a very simple method, maybe too simple, but he also acknowledges that, to compare the intervention measures in about 130 different places. The problem here is you're working with observational data. There is no study being set up doing masks and no masks and so on, although you could have a debate about that. Let's not do that now. But it's all observational, so you have a lot of confounders you have to deal with. Nevertheless, if you try to disentangle these features, some of these things point in the same direction, but you can't claim causality because of that. And so it's very difficult, and the mask question is the most sensitive one, I think, at this very moment. The mask question, what you see, and sometimes people do populations with wearing masks, without wearing masks, and so on, but that's an ecological fallacy, likely, that you see curves being lower there and over there, but not completely, maybe, and then we don't know. The fact is that the populations where masks wearing was instated immediately do a better job, but maybe that also means that the epidemics has been taken a bit more seriously or differently or more effectively. So it's still very difficult. And then the other bit that is very important in trying to disentangle the effects of intervention measures is that most intervention measures were implemented at the same time, especially during the first wave. And you had lockdown. What did that mean? Only essential sectors still open. Schools were closed. People should stay at home, and so on. So you could not disentangle all these things. I think it's nevertheless a useful exercise to look, for instance, at what is happening now, the more stringent measures that have been instated in Antwerp. But you have to be very careful to compare that. I wouldn't make any strong claims about that. But of course, we try to learn from these signals as well.
All right. Maybe with that, we're at 1 o'clock, so it's time to wrap up. Niel, thanks once again for, besides saving the country with science and doing your professor work, also making time for our community of Data Science Leuven. It was an honor for us to have you here, so thank you very much for your time and your explanation. And with that, I would like to give the final word to Lien, who has like an announcement of our next meetup. Lien, the floor is yours.
I really don't have much to say. It's all on the slide, but everyone, please join us again on September 29th, our first meetup of the new season. I can't announce any speakers just yet. It will be hosted on YouTube for some time to come. We'll see. But I hope you all learned something today. I definitely did. Thanks again, Professor Niel Hens, for being here with us, and see you soon. Bye,
Thanks
everyone.
for joining. See
Take
you
care.
next week. Bye.
Let's do one last wash hands emoji on YouTube, our favorite emoji. We've replaced our applauses with wash hands, Professor. I think you can appreciate that.
All right. Take care,
There we are.
everybody.
Our first.
Bye.
All right.